fellow at Emory University. So we have a 85-year-old Caucasian gentleman that was completely asymptomatic. He had a past medical history of some cardiovascular disease and a family history of colorectal cancer. He was a never smoker, didn't use any alcohol, and he was referred to us just for a procedure of diagnosis of his incidentally detected mediastinal adenopathy. So he had a oncologic history of papillary thyroid carcinoma. It was incidentally detected actually from an elevated PTH level that was found during an evaluation for hypercalcemia. He had the usual diagnostic workup, a thyroid ultrasound, bilateral FNA that actually did reveal left-sided concern for thyroid carcinoma. So he underwent a total thyroidectomy and a parathyroid resection that did reveal a 6-centimeter left-sided follicular papillary thyroid carcinoma. He was treated with radioactive iodine therapy, and then he was undergoing active surveillance when an enlarged left level 4 lymph node was detected. This was biopsied with a FNA, and it was found to be consistent with papillary thyroid carcinoma. He then was being considered for a radical neck dissection, at which time he underwent a chest CT that detected this mediastinal adenopathy, which upon review was actually found to be present several months prior, but was not biopsied at that time. So this is the axial view of the CT showing the left level 4 lymph node, as well as the prevascular lymph node, as well as the right paratracheal lymph node, as the right precarinal lymph node, all of which were enlarged. So he underwent an EBUS-guided, endobronchial ultrasound-guided transbronchial needle aspiration of the right paratracheal lymph node, which, surprising to us, had a very cellular sample, and the papiniculus stains were not consistent with papillary thyroid carcinoma, as was the diff-quick was not consistent with it either. But upon immunohistological stains, we actually were able to note that this was prostate cancer. And it stained consistent with prostate cancer from all of the prostate-specific immunohistochemical stains. The prostine, the PSA, the NKX3, as well as the prostine. So upon further discussion, he actually did have a history of prostate cancer. Was diagnosed in 2008. He had previously been treated with external beam radiation therapy, seed implants, and hormonal therapy. His last PSA was relatively low at 8.4, and there was no PET avidity noted in the prostate. So once this diagnosis was made, he was initiated on therapy for prostate cancer. He had a rising PSA, and he was started on anti-androgen therapy. Given his age and his comorbidities, he actually preferred to have a conservative treatment plan. So as was previously mentioned, prostate cancer does commonly metastasize to the bone, as well as to the local regional pelvic lymph nodes. And this usually is much more correlates with a rising PSA level. Cervical lymph node metastases are very uncommon. It's usually left more than right. I was able to note that the incidence is usually less than 1%, and it is usually associated with significantly elevated PSA levels, which our patient did not have. He did have, the incidence of concomitant head and neck, specifically endocrine malignancy, is unknown in people that have cervical mets of prostate cancer. So this is an interesting case, and the diagnosis was made more challenging by his history of papillary thyroid carcinoma, making the concern for prostate cancer much lower on the differential. It's something to consider in patients that have, especially elderly patients, that have new mediastinal or cervical adenopathy, and that the diagnosis was really clinched by the immunohistochemical staining.
So based on your conversations with the pathologist about this case and your review of this, would you approach EBUS biopsies differently if somebody had suspected lung cancer versus maybe there is some other cancer going on in terms of how much tissue you get, how many nodes you sample?
Sure, absolutely. We were fortunate to have a very cellular block, so we were able to run all of these stains. Of course, you want to be as aggressive as you can with getting the sample under one procedure. I don't think that from looking back at this that we would do anything much differently. We were looking and expecting to get thyroid cancer. So,
John and Jerry.
Yeah, just a last question, because it brings, the follow-up on that is, as we're hearing more on all the genomic testing and everything, and what we just heard here is 4 different types of cancers that we get diagnosed in mediastinum that, could very much have looked like lung cancers. So the question is, especially from a pulmonary standpoint, a critical care standpoint, the bigger needles, the core biopsies and things like that. We got very good at going away from them, and I know we really need to go back. And I know some institutions are. What are you doing there?
Sure.
Your institution, are you really trying to get cores, if ever, or I know it's
Yes.
a little bit riskier, but how are you guys approaching that?
So this was actually made with the 22 gauge EBUS needle, which is the smallest one, and we were able to get significant cellularity from it. Have we used it? Yes, we've used some of the larger 19 gauge needles, specifically more for concern for lymphoma diagnosis, to be able to preserve as much of the architecture as possible.
Jerry?
Correct. From the reading that I've done, very minimally. It's usually been that the PSA levels have been significantly elevated at the time of diagnosis. I think it's a little less common.
What's the largest bore needle that you can go in with an EBUS?
The 19 gauge.
19.
Mm-hmm. Traditionally, yeah, I'm sorry.
That's a good core.
Yeah.
Right.
Yep.
Right.
Correct.
Right.
Correct. You can get as much as you. It's not. Correct. It's still not an excisional lymph node biopsy, but yeah.
So it makes a difference, because when you look at the Roche COBAS assay, it's only validated on core biopsy samples. So if you're going to do a trial with the Roche assay, you cannot run it on an EBUS specimen.
Yeah, and same thing with, there's some other of the drugs that are targeting the microenvironment that require the architecture. So, so for EBUS, though you can get, core, you can't get core with architecture because it's too short of a needle, or?
I actually don't know the answer to that. Yeah, I'm not sure about that.
I don't know if anybody knows, because,
No.
you would think it's usually the gauge that's important, but it depends on how long of a piece you can get out of that.
I mean, it's well known that you can get enough cells
Mm-hmm.
with repeated aspirates from EBUS to do molecular testing. And I don't think that's a limiting factor. So
I think it's more the architecture of
Correct.
where you
Right.
lose it with those.
right. But the clinical scenario where we really need the architecture, at least based on what we have in our therapeutic realm right now, is not as significant. So great. Thank you. All right. We are 10 minutes early. I'll turn it over to John.